Hi everybody, Dr. Britt Daniel. I'm a neurologist, electromyographer, live in Dallas, Texas, member of the American Academy of Neurology and the American EMG Society. I've given other talks on YouTube on carpal tunnel, but this talk I want to discuss how does splinting help carpal tunnel syndrome. To do that, I'm going to start off showing you some of the anatomy. Here's a picture of the brachial plexus, which is a group of nerves up in the shoulder area. And you can see those nerve roots join together, and down here they form the median nerve. And then the median nerve looks like this. Comes out of the fibers. The central area is the spinal cord. They go through the plexus, and they become superficial right there in the humerus, head of the humerus. Go down the front of the arm, underneath the biceps muscle, and then go down the front of the forearm and go through the carpal tunnel right at the wrist. And it gives sensation, as it shows in this picture, to the first, second, third, and half of the fourth digits that's on the palmar surface in about 75% of patients. Okay, the other thing I need to show you is a picture of the tunnel. The carpal tunnel is a tunnel, and it looks like that, where this picture, the bottom part of this picture is the dorsum or the back of the wrist, which has bones in it, and the top part of the picture is the palmar surface, which has a little ligament. And then that little circle in there is the carpal tunnel. It has little flexor tendons, which are cut off in this picture. And the yellow picture is a picture of the median nerve, which is compressed in the tunnel. Okay. So, carpal tunnel syndrome is found in 10% of the world population. And there's a combination of factors that lead into having carpal tunnel syndrome. I'll read you a comment out of the book. So, usually the syndrome results due to factors of a small carpal tunnel by birth. Women have carpal tunnel smaller than men. That's why women have carpal tunnel syndrome 3 or 4 times more than men do. And the tunnel can be small by incidental swelling of the wrist due to sprain, trauma, or wrist fracture. In fact, an early fracture in life, like when you're 12 years old, has bleeding and protein exudate around the nerve, which can scar the nerve, and then later, in 20, 30 years old, you get carpal tunnel syndrome due to the median nerve being damaged at the wrist. Other things that can cause this are diabetes, fluid retention, hypothyroidism, overweight, pregnancy, particularly the third trimester, and mechanical problems in the wrist joint. It's also aggravated by work stress with repeated flexion and extension movements of the wrist, the use of vibrating hand tools, or the development of a cyst or tumor in the tunnel. Okay, those are the factors, combination of factors, which is why people get carpal tunnel syndrome. Now, I'll show you a picture of Dr. Phelan, who's a famous guy in this regard. He was an orthopedic surgeon who actually came and lived in Dallas at the end part of his life. And there's his picture, Dr. Phelan. And in 1950, he wrote 3 articles discussing carpal tunnel syndrome. And he used certain tests. This is before electromyography, didn't have any electrical tests at that time. So he used 3 tests to make the diagnosis. And one of the first tests would be the Phelan maneuver, where you forward flex the hand for 60 seconds, and if the fingers went numb and tingly during that time, that was said to be positive for carpal tunnel. So what you're doing by that movement is you're closing the wrist. So the carpal tunnel is being compromised by that movement. And the other test you get in the office to pick it up is to do what's called the Tinel sign, which is to tap the nerve at the wrist. Doctor taps the nerve at the wrist, and it tingles. And sometimes it'll bring a patient off the table when you do that. It's kind of like you have electric wire that's loose and it shorts out, and it really gets you. Now, in the history of carpal tunnel syndrome, it was before the syndrome had been named, In 1854, Dr. James Paget, I'll show you a picture of Paget, he's a surgeon in London. James Paget, 1854, he operated a case of someone who'd had what was called tardy median carpal tunnel, tardy median neuropathy. Tardy means late, like a student gets to class late. And that had come from a distal radius fracture. And the patient got better with wrist immobilization, which was the first time anyone had treated carpal tunnel syndrome with a neutral splint, which is what we use today. That's what people treat it with. Show you a picture of a neutral splint. You've all seen these. They're in offices all across America. So the splint's got metal on the flexor side there. It's got little Velcro bands that go around and tighten. It's made out of plastic or leather. The important thing about the splint is you should hold the hand in a neutral position straight out. It doesn't need to be tight. I don't want cut off circulation so your hand gets white, gets numb and tingling just from that. You just want the hand held in a neutral position, and that's called splinting. And that's been found to be helpful for carpal tunnel syndrome. So I'm going to read you from the book some articles, an article about splinting. Splinting the hand in a neutral position at night or during daily activities provides relief for symptoms of carpal tunnel syndrome. This involves wearing a loose-fitting splint which immobilizes the wrist. You can get these things all over drugstores. The purpose of the splint is to hold the wrist in a neutral position. It doesn't have to be tight. Common splints are made of cotton fabric with metal stays and Velcro snaps. They should go on like a glove and immobilize the wrist, but we don't want them too tight. Splinting at night helps when the hand gets bent in flex positions and when the pressure of the carpal tunnel has been observed to increase. The pressure of the tunnel increases overnight due to mild edema and decreased venous return. So splinting can help significantly in just a few days. Many persons with mild carpal tunnel wear their splints a few nights when their symptoms trouble them after some activity like painting in the yard, or clipping the weeds, or working with a vibrating buffing machine on the floor. Many patients in offices all over America wear their splints during the day, but not at night. Splinting should always be done at night, and if it helps, then splinting can be done at work or during daytime activities. And it should be reasonably done for usually about 1 or 2 months, depending on the severity of the problem period. If your hand goes numb and tingly while you're driving a car, you can wear the splint and hold it in a neutral position at that time. Okay, so I'm going to quote some literature on medical literature. Does carpal tunnel get better with splinting? So here's an article by Goodman and Gilman writing in the Annals of Physical Medicine in 1962. That's pretty early, on the effect of treatment of median nerve conduction in patients with carpal tunnel syndrome. So not just looking at the clinical symptoms, they're looking at the nerve studies are slow in the median nerve when you have carpal tunnel. They're looking at improvement in the nerve conduction. And these doctors said, although the results of splinting were variable and often disappointing compared with the uniformly good results from surgery, some patients with carpal tunnel syndrome do obtain symptomatic relief as part of treatment. This is one of the first articles showing it worked to some degree. Then Hall, writing in 2013 in the American Journal of Occupational Therapy, we're looking at carpal tunnel splinting, and the final statement was, this conservative treatment program conducted by occupational therapists can improve symptoms and hand function in carpal tunnel syndrome patients. Next, Madsen, writing in the Journal of Orthopedics in 2013, this is a big deal because this was the American Academy of Orthopedic Surgeons. Now, I am 75 and I've been practicing neurology about 50 years. When I came to Dallas in 1982, most surgeons, there was a group of surgeons who operated on carpal tunnel syndrome. In those days, it was neurosurgeons, plastic surgeons, orthopedic surgeons, and hand surgeons. And also some general surgeons did it. But as time has gone on and the growth of hand surgery has come out in the orthopedic group, most people have been referred to that unless you're in a small town that doesn't have a hand surgeon. But anyway, this is a survey on the use of splinting from the American Academy of Orthopedic Surgeons. All right, and they found that 98% of these members advised nighttime splinting for non-operative treatment of carpal tunnel syndrome. Then Paulson, writing in 2014 on the long-term results and patient-reported outcome of wrist splint treatment for carpal tunnel syndrome, thought that, and I quote, splinting, reinforced splinting as a first-line treatment for primary care setting for treatment of carpal tunnel syndrome. Now, if you look at the internet and you Google treatment of carpal tunnel syndrome, you got a lot of goofy stuff. I'll make a comment here. This was a study done in 2003 by O'Connor, writing from the Cochrane Neuromuscular Disease Group. The Cochrane Group is a database group out of England which gives advice on medical therapy for a lot of things. The title of the article was Non-Surgical Treatment Other than Steroid Injection for Carpal Tunnel Syndrome. So they did these trials involving ergonomic keyboards, trials of magnet therapy, laser acupuncture, exercise, or chiropractic care, and they stated they did not demonstrate symptom benefit when compared to placebo or control. And yet there's a good literature on carpal tunnel syndrome being treated adequately, as I've just read you, by using a splint. So another thing about the splint would be well, take a normal person that doesn't have carpal tunnel syndrome. They did a study where they stuck a wick, which is like something that measures the pressure in the wrist, kind of like the blood pressure in your arm. So they measured it in normal persons, and it was 2.5 millimeters of pressure in normal people when the hand was straight out. But when you bent it like that, it went up to 31. But when you did that to a patient with carpal tunnel syndrome, you stick the wick in there, it was 32. It's always very high. And when you went down like that, it was 110, which is 3 times normal. So the pressure inside the wrist is what, on top of the median nerve in a small tunnel, with doing these activities, what aggravates this. So I'll make a closure statement saying thank you very much for listening. If you want to get my book, it's on Amazon as an ebook or a print book. You just go to Amazon, in the search engine, you bring up my name, Rick Talley Daniel, all my books are there. Good luck to you. I hope you have good treatment for carpal tunnel syndrome.